Psychotherapy is about people finding a way of getting along with their own internal systems, basically. So that's what the treatment is always about.
That was Dr. Bessel van der Kolk. He's the world's leading expert on the treatment of trauma. And to start us off today, I want to zero in on something he just said. Psychotherapy is about helping people find a way to tolerate what they're feeling, what they're experiencing in their body. Now, I'm paraphrasing Bessel a bit here, but the point is, this may never be more challenging than when we're working with people who have experienced trauma, because by its very nature, trauma can disrupt our clients' internal systems. And when that happens, it can become very easy for some clients to fall into near constant cycles of reactivity, hypervigilance, or fear. That's why it can be critical for practitioners to know how to employ the kinds of interventions that can help clients short-circuit old patterns of reactivity, ground in the present, and learn to tolerate their feelings and bodily sensations, and learn how to regulate. Hi, I'm Dr. Ruth Basinski, a licensed psychologist in the state of Connecticut and the president of the National Institute for the Clinical Application of Behavioral Medicine. Now, I just want to start off with a message to the people watching who aren't practitioners. Now, this program is made for practitioners, people who have studied for years and have advanced degrees and, for the most part, have licenses to practice. But I know that a small percentage of our audience is made up of lay people each week, people who don't practice in the field. So, first of all, I want to tell you, you are welcome here. But the second point, and this is really important, the second point that I want you to hear is that trauma is not a life sentence. I want you to hear that message clearly. In my descriptions of trauma and the trauma experience, I've been careful throughout to say like certain things that can happen. That doesn't mean that they will happen. And even if they do, that doesn't mean that you can't heal and grow from the experience. So while it's certainly true that trauma can be devastating, it shouldn't be the way you define the rest of your life. Okay, let's continue on. In this session, we'll be shining a spotlight on specific ways to help traumatized clients tolerate distress. We'll look at hyperarousal, but we'll also look at hypoarousal. Now, we generally tend to talk a lot more about hyperarousal than hypoarousal, but today we really want to shine a light on hypoarousal because it's important to know how to bring a client out of it. Not only that, we'll also share one practice that can be particularly effective in helping clients bring their thinking brain back online after trauma. Plus, we'll talk about the critical difference between a brain state where someone is processing trauma versus when someone is reliving trauma. And toward the end, we'll give you one key symptom that can help you know whether you're working with bipolar disorder versus trauma-related dysregulation. Okay, so let's jump right in. To start, let's first look at how trauma affects self-regulation, particularly childhood trauma.
Early childhood trauma, for example, surgery is a trauma. A child can have surgery, but have the integrated and consistent support of the parents who insist on staying with the child at the hospital, etc. Okay? So the parent is there helping the child regulate the whole time. Okay? So that could be early childhood trauma, but the parent is there and helping the child integrate and regulate. That is very different from a childhood trauma that is perpetrated by the attachment figures, where you don't have your attachment figure to help you regulate because they're also the threat, and it's the effects are much stronger if there's a long duration where the parent is the threat. Okay, like if the parent loses it and hits the kid, one or two times, but otherwise really regulates. That's very different from the child who's hit on a regular basis over a long period of time. So there's different degrees of childhood trauma. And then, of course, we're getting into attachment patterns. Is there an ambivalent attachment, an avoidant attachment, or a disorganized attachment, right? And all those have their effects on self-regulation.
Now, in session 2, we went in depth into the neurobiology of attachment. And by the way, if you missed that or any of our prior sessions, you can have your own permanent set of the audio, the video, the transcript of every one of those sessions by signing up for a gold subscription. But getting back to attachment, let's just stay with it for a moment to really consider how attachment affects our client's ability to self-regulate. In particular, let's look at how attachment can affect self-regulation for someone who has experienced trauma versus for someone who hasn't experienced trauma.
Well, a non-traumatized person with a secure attachment has the capacity to both regulate independently of relationships, like if they're upset or, something happened, if they're triggered or whatever, they have the capacity to bring their arousal into that window of tolerance. They'll go for a run, they'll self-soothe, they'll curl up in bed with a good book, they'll have a nice cup of tea. They can auto-regulate by themselves independently of others. But they can also, this is what traumatized clients often can't do either, a securely attached person, they can also use interactive regulation. So they can reach out to another. They can call a friend and say, I need to talk. Can I come over? They can interact. They can use interactive regulation as well. And both of those are really critical, right? Traumatized clients often have trouble with both, especially if they've had an insecure attachment. They have trouble regulating by themselves, but they also have trouble seeking others and taking in the support and the regulation of others. So we want to address both those. And we want to address the ability to use interactive regulation, to reach out, to call a friend, and we want to address how to auto-regulate independent of relational contexts.
Now, I'm wondering whether you might recognize some of these patterns in a client you've worked with, especially if they've experienced trauma. So before we move on, let's just look for one moment at how early life trauma can affect self-regulation. Because according to Bessel van der Kolk, there's an important distinction that we really want to pay attention to.
See, self-regulation primarily affected by early life neglect, abuse, and abandonment, actually. And I really am trying to push the field more into making a distinction between trauma and disorganized attachment. So disorganized attachment is very bad for your capacity for self-regulation. Not being seen and not being known and not knowing that somebody will come to your rescue when you get upset tends to predict a lifelong pattern of dysregulation or having to do a lot of hard work to make up for what you didn't get as a kid. And so it's very clearly, if you look at the work particularly of Cardinal Ruth, who's prospectively studied these kids with disorganized attachment over a 20-year period, and that she saw that clearly what she saw at age 2 in terms of disorganized attachment predicted self-regulatory problems at age 18, 2022 in a major way. And so it's not trauma, it's the attachment system.
So just by way of quick review, disorganized attachment is what can happen when a child grows up with a parent or primary caregiver who is largely unpredictable. So the child very often just doesn't know what to expect from one day to the next, or in some cases, perhaps one moment to the next. And what compounds the problem is that the child often can't find a way to cope with this kind of inability, this unpredictability from an attachment figure.
About a third of kids have mothers who are not very good to them, who are too traumatized, too upset, too depressed, too drug addicted, too preoccupied to really pay attention to the kids in the proper way. Most kids actually find a way of coping with that by either shutting themselves down and going on mechanically, one way of coping with it. The other one is by continuously asking for attention, becoming a little bit of a pain in the ass. But the worst thing is that is a kid, the environment is so unpredictable that they don't find a consistent way of dealing with their environment, and they just do anything at any time to just cope with whatever happens in a very disorganized way. And it's that 10% of the population about that goes on to have the most serious psychiatric problems.
So with regard to disorganized attachment, Bessel points out two specific coping skills that a child might adopt. Number one, by shutting themselves down and going about life sort of mechanically or emotionlessly. And number two, by becoming a virtually constant attention seeker. But it seems that the most dire prognosis for some people who have experienced disorganized attachment is not being able to find any consistent way to respond or cope with their environment. Now, of course, all is not lost, because now that we've looked at the relationship between trauma, attachment, and self-regulation, now we want to start looking at treatment. So here's where Bessel begins every time when it comes to helping clients learn to self-regulate. Maybe you do too.
When somebody walks in my office, I look at the way they walk in. I look at whether they're able to make eye contact. I look at their breathing. So one of the first things I do when I sit with people is I look at whether they actually are able to live within their rib cages. And I may spend the first hour with a new patient helping them to just open up their rib cage and to breathe. Because as long as the primitive part of your brain is all uptight, it's no use to do psychotherapy with them. So when you start off with the most elementary arousal systems of the body. Every session I do that with everybody.
So it's from this starting point that we might best begin to assess how to resource our most traumatized clients with skills for self-regulating. The next thing we want to consider? Well, we want to keep in mind the window of tolerance.
When I think about self-regulation, I really think about that optimum window of tolerance, right? That in a non-traumatized client with good self-regulation skills is really quite wide. So, they have a broad window of tolerance. And of course, you have to be in that window of tolerance to be able to think clearly, to have good relationships, to plan for the future. If you're outside that optimum window of tolerance, all those abilities, I think, are very much affected. And so when we think about our traumatized clients who have great difficulties with self-regulation, I always think of that optimum window of tolerance shrinking, right? So it's very narrow, and usually they're either too hyperaroused or too hypoaroused, which prevents them from thinking clearly, of being involved in stable relationships, prevents them from being really able to function at work, because they're constantly juggling either hyperaroused or hypoaroused states. So I think self-regulation is all about being in that optimum window of tolerance and widening that optimum window of tolerance through emotional awareness, through learning how to regulate your emotions, and through really coming into your body and feeling safe in your body.
That was Dr. Ruth Lanius. Ruth is professor of psychiatry and director of the Post-Traumatic Stress Disorder Research Unit at the University of Western Ontario. And she's just given us an excellent sort of snapshot of Dr. Dan Siegel's concept of the window of tolerance.
I use that phrase to describe the space or the zone of optimal arousal within which information can be effectively processed and integrated. And that means integration of information from externally, like what's happening in your world, as well as internally. And when trauma happens, arousal bursts through that window of tolerance and goes way up, and it can also drop way down under that window of tolerance. And in those two arousal states, you can't really process things effectively.
That was Dr. Pat Ogden. She's an expert in somatic psychotherapy and the founder of the Sensory Motor Psychotherapy Institute. Now, in many ways, the treatment of trauma is very much about working to expand our client's window of tolerance. Real quick, when we're talking about this window of tolerance, we're basically talking about this sort of equilibrium between our different systems that helps us regulate during times of stress. As Pat said, when arousal gets revved up, it can move the client way above their window of tolerance. So we have to bring them back down. Now, as we also heard, arousal can plummet, which can drop your client below the window of tolerance. But we also have to remember that different circumstances can affect the size of our window. Our window can shrink when we lack the skills or the healthy attachment models that can keep the window open. So let's look at how we can help our clients expand their window of tolerance.
If we know how to do it for ourselves, we know how to do it for other people. Because most of us are patients. So let's face it. And so how do we expand the window of tolerance? By learning to be calm and to stay focused and activating that mindful brain. And so what's very clear is that we have these midline structures, and the midline structures of the brain are the interoceptive parts of the brain, and we can only really become masters of our own ship by activating these interoceptive structures of the brain. That means in order to be in charge of ourselves, we need to shut up, be still, and notice what goes on inside. And to notice the flow of our internal states. And there's no other way of doing it again. Like, got to do that. It's like, you need to just really pay attention to what goes on inside of yourself and notice what comes up. And it can be very scary. And that's why we have therapists who can help us to guide us to keep paying attention to our internal world and our internal flow, and to give us the courage to notice what we notice inside.
So one way to help clients widen their window of tolerance is by activating the parts of the brain that are involved with interoception. Now, as you know, interoception is basically that sense that helps us understand and process what's going on in our body. And so it follows that people who struggle with interoception also struggle with self-regulation. So by working with mindfulness and presence, we can help people activate the interoceptive parts of the brain and thereby help boost their capacity to self-regulate. Now, if you joined us for week 1 of this series, you might remember that presence can also be a major catalyst for boosting integration and even for reducing inflammation. Presence is being conscious of ourselves, of our movements, and of our thoughts and our feelings. And now we see how presence can also play a role in expanding people's window of tolerance as well. But as you'll hear in just a moment, broadening a narrow window of tolerance can also involve assessing a client's dysregulation.
So when a client has a narrow window of tolerance, they don't have much room in their experienced life. They have so many triggers that cause their arousal to shoot up or to drop down. So in our work, we want to start really working at the edges of the window. If you stay in the middle of the window, if arousal's just in the middle, you don't access any dysregulation, and thus you can't regulate. You can't help them regulate. If you think of a baby who gets dysregulated, and then the mother or the father comes and holds the baby and soothes the baby and calms it down, okay, that baby's window of tolerance starts to widen, and they start to develop those connections between the cortex and the subcortical brains. And if we think of that in therapy, it's really the same. We're working at the edges of that window, okay, where dysregulation happens. And then we're staying at that edge, say with hyperarousal. We're staying up there with that hyperarousal, and we're helping them process and re-regulate. And in that relational somatic, emotional, cognitive endeavor, their window of tolerance starts to expand and expand more and expand more and more and more.
So being comfortable around dysregulation and knowing how to stay with a client's hyperarousal can be an essential part of helping clients expand their window of tolerance. But before we can begin to work with their dysregulation, we might need to help our clients learn to tolerate the dysregulation in the first place. So how would that work?
I would give them tools that they could potentially use to self-soothe, because the tools would be relatively simple. And I would demonstrate to them the effects of these simple tools. So when people change how they breathe and they start to exhale more slowly, it's a calming to their body. And they can just compare that to a more of a hyperventilation, or where they're doing much more on the inhalation, where people literally get themselves vocalized. And when they get angry, their breathing changes, which supports their anger. And you can actually walk them through these different stages.
That was Dr. Stephen Porges. He's the creator of the polyvagal theory, and he's just given us a look at how breathwork might help us. When it comes to assessing a client's dysregulation or helping someone through hyperarousal, we want to get them to change their breathing. Specifically, we want to get them to slow their exhalations in order to help them calm their body. Now, so far, we've talked a lot about hyperarousal, especially with regard to the window of tolerance. That's because when we think of dysregulation, we often think more about hyperarousal. And because, of course, this state of heightened anxiety is quite common for people with PTSD. But we also very much need to keep in mind how to work with someone who is in a state of hypoarousal. That's when the body slows down and even begins to shut down. As you know, people can fall into hypoarousal when they're not able to fight back or to flee from danger. So let's think for a moment about our clients who have experienced trauma in a situation where they couldn't fight back or get away. For them, hypoarousal might have been a very common adaptive response. So now, let's take a closer look at what's happening when someone is hypoaroused.
Well, in hypoarousal, the dorsal vagal system has, increased tone. Sometimes a client has a hard time moving. They start spacing out. They don't feel present. At those times, there's no one size fits all.
When someone is hypoaroused, they can often slip into immobilization, and immobilization can sometimes downgrade into a feigned death response. The feigned death response is sort of our last resort option in the face of trauma. We might default to it when no other escape route is available. Now, ideally, you'd want to try and prevent a person from entering into this response to begin with. But sometimes it can happen very quickly.
As they're starting to slide down towards that immobility, you want to catch them before they really drop way down, because it's harder to get out of it once you're way into it. So you want to track for the spaciness, you want to track for that stillness that starts to happen, and then you want to reestablish social engagement. What's happening right now? Can you feel your legs? No, I can't feel my legs. Okay, you know what? Let's just stand up. You and me. Let's stand up. Let's walk around the office a little bit. Feel your feet on the floor. And so you do a little bit of movement, and you help them come back and help their arousal come back up into that window. Sometimes people don't track for the signs. This has happened to me a few times. And then they can't move, and they often even become mute. They can't talk, right? So at those times, and with highly dissociative cases, like this can happen frequently. And you have to find ways to help them come back.
So let's look a little further into how we might help them come back. Well, as Pat said, the first way is through movement. Movement is a very important catalyst here. The second way is by talking with the person about the parts of the self. Because according to Pat, When trauma causes a dissociative response, our clients can develop parts of the self that don't communicate with each other. And so in those cases, we're trying to help clients work with their fragmented self. Here's an example.
Like I had one client where she said in her previous therapy, she said she just wanted her therapist to slap her because she couldn't get out of that state. And the first session she had with me, she couldn't remember afterwards. She was highly dissociative. And so when she came back for the second session, and I asked her about the first session, and she said, I don't remember it. That was a real cue for me. And so we started talking about, okay, so there's this part of you that can go into that state. And when you get into that, it's like you become that part. So let's start finding the triggers for that state. Let's start finding the bodily sensations and movements that start to happen so we can catch it before you go all the way into it. So for her, she would start to feel her eyes kind of shift in some way. That was like the precursor to really going into that state. So that became a helpful bodily element that she could watch for and catch it before she went all the way into that hypoarousal.
Now, one important thing to note here, hypoarousal and dissociation are connected some of the time, but not all of the time. Someone can experience hypoarousal without moving into dissociation.
Yes, absolutely, because low arousal is really our dorsal vagal system, that one branch of the parasympathetic system that helps everything slow down. So we can co-opt the dorsal vagal system, say, to go to sleep at night, to relax with a loved one, during savasana and yoga definitely stimulates the dorsal vagal system. One of the difficulties with traumatized patients is that immobilization is coupled with fear. So when they start to become immobilized, they become fearful, which prevents healthy sleeping patterns, prevents being able to rest.
So it might be worth noting here that the dorsal vagus is also what helps the client shift gently back and forth between arousal and relaxation. And when it shuts down, that's when our traumatized clients can start to experience the kind of difficulties that Pat is talking about. So now that we've looked at the contrast between hyperarousal and hypoarousal and how each can affect the window of tolerance, now let's look at how we can move a client back into their window of tolerance once they've slipped out of it.
It depends how far out, and it depends on the client. Like if somebody is just out of the window of tolerance, I'll often look for a bodily resource or a relational resource. I mean, sometimes it's enough to say, okay, can you look at me? Like, this is Pat. You're right here in the here and now. Can you sense that? Can you sense this moment? Often when a person's really outside of the window of tolerance, they're in what Arno van der Hart calls trauma time, which is an expression I love. They're not here in the here and now, realizing that they're safe, they're with somebody who can be trusted, they're back in trauma time. So helping them somehow orient to the here and now through the relationship, through movement, through a resource like breathing or lengthening the spine or feeling your feet on the floor or containment, some kind of containment exercise can help a person come back into the here and now.
Pat's just given us some good guidelines for how to help a client shift back into their window of tolerance. To do it effectively, we first need to consider whether they're just a step or two outside of it or way outside of it. When a clients are just a bit outside of it, we might do it relationally by bringing the person's attention to the present, for instance. But when a person is in trauma time, a bodily approach might be the more effective way to go. And we can do that through movement and breathing, just to name a few. Now, let's go back to look at the brain for a moment and look at how the brain deals with stimuli. To do this, we need to introduce a new term, evoked response potentials.
Evoked response potentials is a way of measuring how the brain engages with novel stimuli and makes distinctions. And so in order for the brain to engage with something, it needs to have two capacities. One is to ignore irrelevant stimuli. There's a certain wave that the brain generates. As you talk to me, I have this little wave that says, don't pay attention to whether you're hungry right now or that you have to do next. So stay focused. And the next thing is you need to fully engage with what's going on, pay attention, and to evaluate what's happening. And so what was discovered in PTSD is that people have a hell of a time filtering out irrelevant stimuli and have a great time getting fully focused on what's happening. And what we saw clearly here, how hard it is for many traumatized people to really learn and to grow from new experiences, because there's some fundamental deficits that get in the way of absorbing new information.
So to review, trauma can impair a client's ability to stay focused, to ignore certain stimuli, and to engage with the present. And because of that, it can be hard for people who've experienced trauma to learn from new experiences. And that's because without focus, we can't absorb new information. So in treatment, we need to focus on two things. Number one, we want to retrain the brain so it can begin to ignore any irrelevant stimuli. And number two, we want to help the brain to fully lock in on the present and evaluate what's going on. But when a traumatic experience has derailed the client's natural ability to do those things, how can we help?
We train the brain with neurofeedback. That's my main research these days, is on neurofeedback and seeing how you can alter those things. It's the only thing that I know that can do that. I don't know anything else that can. Although I suspect that boxing, martial arts, and playing music in a band can also do it. It's all about getting in sync with people. It's all about, I'll have to beat when the guitar plays that, I need to play it. When you're boxing, somebody comes at you, you need to duck at the right time. It's all about rhythm and interaction. That's living in the present.
So we want to strengthen someone's ability to engage and stay focused on novel stimuli. Bessel noted three things in particular that can help: neurofeedback, getting in sync with people, and living in the present. So in addition to retraining the brain for better focus and engagement, perhaps the larger goal here is to help clients learn to self-regulate and tolerate distress. So how do we do that?
I think you learn self-regulation by noticing your distress and continuing to go on even though you notice it. And so meditation is a great way of doing it. And so sitting still and noticing when stuff comes up, to just, I wonder what happens if I take another breath. I wonder what happens if I sit here a little bit longer. To enlarge the window through which you can learn to tolerate your distress. But of course, a great way of doing it is to do the ancient practices that the Chinese and the Japanese and the Indians developed in terms of yoga, meditation, Zen practices, Taekwondo, Qigong. All these practices are mindfulness practices, basically.
So there's mindfulness again. And what you've just heard is another way that mindfulness can play a role in healing. In this case, by helping people increase their distress tolerance. Now, as you might know, there's a little more about mindfulness that we need to talk about, especially when it comes to asking some clients to sit still. Because for people with unresolved trauma, sitting still could actually be extremely difficult, even distressing. So next week, we'll be getting into why that is. But while we're at it, there's another mindfulness-based practice that we might also need to modify for people who've experienced trauma, and that's the body scan. In fact, if you're a gold subscriber, you'll be getting a special bonus on one way to do this. And in this bonus, you'll hear about how to identify when a client's response to trauma is protecting them and when it isn't. Okay, so getting back to the topic at hand, yes, mindfulness practices can indeed be useful for helping clients learn to endure distress, as long as we're aware of the precautions that we might need to take. And we'll be getting more into that next week. But there's still one other important ingredient for helping clients build up tolerance for frustration, and that's acceptance.
The whole notion of acceptance is very important here, and it's a very difficult thing for traumatized clients because often they feel that acceptance means that you like something. And so I think it's really important to teach people that acceptance is not about liking something, but accepting the present, keeping in mind that, we're learning in therapy something that can help them change and improve how they are. And so I think, bringing this notion of acceptance into therapy early is really important because so many of our traumatized clients spend so much time pushing away their distress and, not accepting it. And of course, that makes the distress worse. So the more you try to push it away, the more intense the distress becomes. But as over time, our clients learn to accept it more, basically accept the stance that I'm in agony and it's horrible, but I'm learning skills to change this.
Now, I want to key in on one thing in particular that Ruth just said, and that is, it's very often avoidance that can make a difficult situation, almost any difficult situation, avoidance can make it even worse. That's why working with acceptance can be essential in the treatment of trauma. So now, let's take things even a further step, because we also want to consider a few brain-based ways to help traumatized clients strengthen their ability to self-regulate. So first, let's go to the brainstem, because according to Stephen Porges, the brainstem is a place we might need to think of as a pivot point.
It's a pivot point between higher cortical or cognitive functioning, higher brain structures, and the body. And the brainstem is, in a sense, it's very primitive, very old, through evolution, through our phylogenetic heritage.
Now, in addition to being a pivot point, the brainstem also has another role, and that role is being our innate alarm system. But here's the thing. When someone has experienced trauma, this alarm system is often kicked into overdrive. So when that's the case, how do we help the clients retrain this alarm system? In other words, how can we help them reconnect the brainstem response with higher brain functioning, the thinking brain?
I think that's a great question, Ruth, and I think that's exactly what's at the core of trauma, right? Is that these lower brain structures function independently of the cortex, the upper part of the brain, that can actually engage in top-down modulation. So we have all these circuits that are running crazy, and we've lost that top-down control. And so how to reestablish that? And I think, this is really what we do in treatment. And I think there's two ways to go about that. One way is called a bottom-up approach, and the other way is called the top-down approach. And probably using a combination of bottom-up and top-down approaches is most effective. So a bottom-up approach would be, working, with defensive action, working directly with the midbrain, helping to complete those defensive actions, such as the sensory motor psychotherapy or Peter Levine's treatment. That would be a bottom-up approach. Another therapy that's recently been published on is the comprehensive resource model, and that therapy is aimed to directly work with the emotional responses that are generated at the midbrain level. This is a treatment that really tries to resource people, and in a resource state, then encourages them to step into the emotion that they felt at the time of the trauma. and then allowing through breathing and processing these emotions, them to be processed. And the hypothesis is that by dealing with the affect or the emotion at its root, that you re-regulate the brain from a bottom-up kind of perspective and bring online these upper parts of the brain that can then regulate the brain top-down.
So to summarize, Ruth just highlighted two bottom-up approaches in particular. Number one, helping clients to complete their defensive actions, which involves working directly with the midbrain and employing the sensory-motor approach to psychotherapy. Or number two, using the comprehensive resource model approach that focuses on working with emotional responses that are generated at the midbrain level. But top-down approaches can be equally effective in the treatment of trauma. One example of a top-down approach that we might use? Well, cognitive behavior therapy. So ideally, you'd be teaching people how to think differently about the things that affect their emotions. But often, there's one key factor that needs to be in place.
I think what's important to be aware of is, if this disconnect is very prominent, where the lower parts of the brain are disconnected from the upper parts of the brain, if that is extreme, how much working with the upper parts of the brain can affect the lower parts of the brain if you have a disconnection. So how much do you have to reconnect before using upper parts of the brain to regulate lower parts of the brain, I think is really important. And I don't think we know this at present. But I think, taking the approach, working both bottom up and top down over time, I think will really strengthen these connections and really help the person then be aware of what they're feeling, intervene early, being able to regulate their feelings, and being able to connect these intense feelings with what may have happened in the past and make sense of them. So if they feel really overwhelmed in the present by something that may not be all that triggering, but if they feel an intense emotional response, slowly becoming aware of the fact that this must be triggered by something in the past, and how can we overcome this?
Now, Ruth has just given us a useful framework for using a combination of top-down and bottom-up approaches with a client who has experienced trauma. So next, let's look at another way to help clients reconnect higher brain functioning with their brain stem response after trauma. Or to put it a different way, how we can help someone who's been traumatized bring their thinking brain back online.
I think mindfulness is key here, because traumatized clients will not have that cortical connection when they're having that trauma response. If we take that window of tolerance and arousal is outside of the window, their thinking brain is not online. Not at all. Often not at all. So for me, helping them reconnect it has to do with accessing a little bit of that reptilian brain response, and then having them report what that feels like to tell me and to stay socially engaged with me. So if a client says, I see that mugger coming towards me and I'm starting to tighten up and I can't move. We're going into a freeze response, which is a reptilian brain instinctive response. I would say, okay, let's stop right there and just feel your body. Can you tell me where the tightening is?
Now, whichever way the client answers, you might then say to them, okay, let's stay with that. And as you stay with the tightening, what are you experiencing? And ask them to tell you about the sensation, whether it's sharp or dull, constant or intermittent, details like that. Because when you do that, here's what you're essentially doing.
So you're eliciting their frontal lobes to describe to you that instinctive reptilian brain response. And I think that really helps the integration. Because they have to experience that dysregulation of those instincts of the fight, flight, freeze, feign death, and the attachment cry too. They have to experience that to be able to integrate. But if they experience that without their frontal lobes being online, that's a reenactment of the trauma. That's not going to do any good. So I insist that a client report to me what's going on. And if they can't, I'll say, okay, let's stop and talk about this. Because there's no point in going on if they can't tell me what's going on and they can't stay engaged with me.
Now, here's the piece we really want to get hold of here. We want our clients to be able to experience their dysregulation, yes, but not unless they can also describe that dysregulation, because that is what brings the brain's frontal lobe online. And that's the key difference between someone who's processing trauma versus someone who's reliving trauma. Now, as we move on, I'd like to talk a little more about the dysregulation that can happen during trauma. Because earlier, we'd said we'd give you one key symptom that can help you know whether you're working with bipolar disorder versus trauma-related dysregulation. This is important because it can help us when it comes to landing on the right diagnosis and therefore, of course, choosing the right treatment.
I think there is one symptom that really helps me to distinguish bipolar disorder from emotion dysregulation. And I think one of the most important symptoms that helps to distinguish the two disorders is sleep. And so in bipolar disorder, when you're in a manic state, the person actually needs less sleep. People will tell you, I got really high and I had tons of energy. I thought I could, control the world. And, an hour of sleep was absolutely fine for me. I didn't need any more. When we hear that, that doesn't sound like our trauma patients, right? They're very different. Our trauma patients often have very chronic and persistent sleep problems. So they will tell us, I couldn't sleep. I can never sleep. I never feel rested when I wake up. And so they may even, be in a state that appears hyper-energized, but often that's driven by anxiety, but it will never be accompanied by, them saying, I didn't need sleep. I was fine on an hour or two. So I think this decreased need for sleep is really helpful in distinguishing bipolar disorder from, this trauma-related emotional roller coaster.
So Ruth just laid out a way to distinguish the emotional dysregulation that can come from trauma, to distinguish that from the manic part of bipolar disorder, and that is through sleep. What we're saying here is patients who have experienced trauma can sometimes have a lot of trouble sleeping. They can get up in the morning feeling very, very tired. And that's very different from bipolar disorder when someone is in a manic state. In that circumstance, the person usually feels like they only need an hour of sleep. And they have times when they get no sleep at all and still feel ready to go. The other point that Ruth made that I think is so important is that we don't want to confuse the hyper-energized state that comes from trauma-related anxiety with the manic state that goes with bipolar disorder. That manic state has a more grandiose sense to it, more of a sense of controlling the world. Okay, so I hope you've heard some new and different things to chew on from this session so far. But we're not finished just yet, because in a few moments, we'll be starting in with the Next Week in Your Practice session. This is content that you'd normally only get if you're a Gold subscriber, but this week we want to share a short piece of it with everyone. In this session, Dr. Joan Borisenko and Bill O'Hanlon will join me to go in depth with a few practical applications that you can use in your work. With a Gold subscription, you'll get the video and audio downloads and also the transcript as well. And that's for the whole series. So that includes the session on what's going on in the brain when someone experiences trauma, the session on the neurobiology of attachment, the session on how to work with traumatic memory that gets embedded in the nervous system, as well as this session and next week's session. You can sign up for a gold subscription right below. And also, your gold subscription is what makes it possible for us to fulfill our mission to continue making this program available free of charge to practitioners all over the world. Okay, so without further ado, let's talk to Bill O'Hanlon and Joan Borisenko. We'll be teasing apart what we just heard from the experts. So let's jump right in with Bill O'Hanlon to find out what his biggest takeaways were from this week's session.
I think this idea of, it's like the Goldilocks thing, not too much, not too little, that people have this place where if they get too scared, too overwhelmed, they'll just shut down, they won't be available. If they're just so hypoaroused, they just don't have the affect or the engagement, it's also not good. You have to find that place, and sometimes we have to help them get there by either down-regulating that negative, as we've talked about before, up-regulating the motivation or the positives or whatever. Otherwise, they're not available. So I think that became really clear, because sometimes you're working with somebody, they're just not available. No matter what you do, you're just not going to get there because they're either overstimulated or understimulated. And I think the other thing that came across to me was that a few people said this week, the importance of observation. I think a lot of times in therapy land, we're in theories, and we're thinking of our theories. And I think what a lot of these experts say is, watch the client, watch their behavior, watch their posture, watch their habits, watch them as they walk in the room, watch how they engage, or if they don't engage with you, watch when they go away, and, really observe. And again, it reminded me, and I've mentioned it many times, one of my main mentors and teachers was Milton Erickson, and I came to study with him. I studied with him for a year in the late 70s. And when I came there, I was filled with theories. I was in graduate school, so of course I was all theory, and I'd studied family therapy, so I was mainly family therapy and systems theorist. And by the end of the year, Erickson just kept reorienting me, skip the theory, observe the patient. All the information you need is right in front of you. The theories are just for you to learn before you get there. Once you get there, stop, pay attention, get out of your head, and get into your senses. They give you every detail and every piece of information you need. But if you miss that, you're going to be off somehow. You're not going to be good connection with them, and you're not going to be getting that information that's so crucial. And boy, that came across so much for some of these experts. They're like, okay, pay attention. Be there in the moment with your client. And, sort of what Joan was saying, be able to tolerate whatever they're going through. You can center yourself and be present. That is so important, I think, in this kind of therapy especially, because the trauma is sometimes traumatizing for us. We get secondary or tertiary trauma just hearing about it. So if you can center yourself and be present, really important.
You make me think of in Gestalt we had the awareness expression cycle, and it focused so much on awareness and how awareness supports aliveness and energy. You stay with awareness and it builds excitement that helps you move into some kind of action, which may only be just being more present, and that results in contact and just staying in that process.
Well, that word contact, which we haven't really used yet, but that from Gestalt, I think that was so important for the client to be in contact with themselves and their environment, and for the therapist to be in contact with the client. That is so important. I'm glad you brought up that word.
Fritz Perls said something very similar. He said, lose your mind and come to your senses. Come to your senses, the awareness. What can you see and hear and taste and touch and smell and so forth. Thanks, Bill. So, Joan, let's talk about the window of tolerance. We talked about that in the session this week. What are some signs when someone's outside of the window of tolerance? And could you share a story of working with someone and what you did to help bring them back into the window of tolerance?
I sure can. And for some people, the cues are more subtle than for others. And so we are called, as Bill said, to become really careful observers. pay attention to whether the person is very inward that day, what their posture is like, whether they're outward, or how they usually are. I had a particular client who had a very specific tell about when she was out of her window of tolerance. This was an older woman. She was retired. She'd taken an early retirement at about 60. And I saw her shortly after that because she was getting progressively more anxious. And she had a history of trauma and abusive father. And she came in one day and she was simply shaking. And I realized, because I saw her for several years, when she was out of her window of tolerance, she had this big physiological reaction. She would begin to actually shake and shiver. Her whole system was just involved in this. And then she was hard to reach. She started to dissociate. And as I got to know her and understand what her resources were and how she put herself together, here's what I did. The first thing, by the way, that I did was just very, very obvious. The first time I watched her do that, I said, "Janet, you're shivering. Are you cold? Tell me about it." And she said, "No, I'm not cold. I'm scared. And when I get scared, I start to shiver like that." So I asked something pretty obvious. "I've got a sweater that I keep in the corner of my office. Would you like to put on the sweater?" And she actually did. So that became okay. Janet starts to shake and shiver. We first start to warm her up. And of course, it's a caring gesture as well. But what calmed her down, what her greatest resource was over the years, was actually walking in nature. And she had a particular woodland where she liked to go and walk. And she just took a lot of joy in that in every season. She was such a good observer of what was happening in the winter, and the little bits of ice that would hang on trees were just terrific for her. Everything was beautiful. Or in the spring when things began to come. And she really would report to me on how things smelled, on the touch. Just as you were saying, Ruth, getting out of your mind and into your senses. And so that's how I would calm her down. I would say, "Well, when's the last time that you walked in your beautiful woodland?" And she would tell me, and she would narrate exactly what it was and what she had seen during that time. And that always brought her back into the present. It was the most reliable thing. And she'd learned to do that for herself. And then in retirement, what she started to do was actually to draw, and became very proficient at really like Audubon type of drawings, not necessarily of birds, but of various features of the woodland. And that was an enormous resource for her. And it was how she would calm herself down. She could just literally take herself back there. So that's what we did. And I think the movement was a big part of it too. For her, that she was walking in the woods, in her senses, in her body, in a totally beautiful environment. If I were Rick Hansen, I would say she had already installed the good in herself and helped to start changing her brain circuits. But when she was dysregulated, boy, she was really dysregulated. Nonetheless, this could help bring her back.
We've got to wrap up now, but as we finish, I just want to say again that you've seen just a short piece of the full Next Week in Your Practice segment. We'll be back next week to look at how to work with the limbic system to help clients reverse the physiological imprint of trauma. We'll zero in on the key ingredient that can make body-oriented approaches so effective. And we'll get into just what to look for in a traumatized client's movement vocabulary. But for now, please go to the comment board and tell us how you're going to use the ideas that you heard tonight in your work. Remember, all the training in the world doesn't matter if you don't apply it to your work. And I just want to say thank you to the Gold subscribers. Thousands upon thousands of practitioners have joined us to watch these sessions for free. And that's thanks to you for underwriting our work. And remember, every time any of us help someone heal from trauma, we change the course of civilization. That's because when healing occurs, not only is that one life changed, but also the person's family, their friends, and even their community. And once people have experienced that gift of healing, you've opened up the potential for new hopes and dreams that they might never have imagined possible. And so they're forever changed. So thank you, everyone. What you do, your work, is so important. Take good care. I'll see you next week.